Good evening, everybody, and welcome to this meeting of the Health and Adult Social Care Overview and Scrutiny Committee. My name is Patrick Canavan. I'll be chairing this meeting this evening. So without further ado, I'm going to ask the Democratic Services Officer if she would read out a housekeeping, please.
Thank you, Chair. Please note that this meeting is being recorded by the Council for live broadcast and will be published on the Council website for a minimum of 6 months. The meeting may also be recorded or streamed for live or subsequent broadcast by members of the public, although ultimate discretion in this matter lies with the Chair. For those in the room, please note that if the fire alarm sounds, please exit the building by way of the nearest available signed fire exit route and make your way to the assembly points in the car park in the front of this building. Finally, please ensure background noise is kept to a minimum. Mobile phones and other devices are turned off or switched to silent for the duration of the meeting. For those in the room, this includes turning off microphones when not in use and turning the volume down completely on your laptops. Thank you.
Thank you very much indeed. And could we take any apologies, please?
Yes, Chair. We've received apologies from Councillor Debman, Councillor Northover and Councillor Slade. And Councillor Matthews confirmed he was joining virtually. As I understand, Councillor Armstrong will be too.
Okay, thank you very much. Do we have any substitute members at all?
No substitute members, Chair.
Okay, thank you very much indeed. So we've now got the items of declarations of interest. So if any committee member has any declarations of interest, if you could please declare it. Otherwise, if something comes up while you remember it, please just flag it then. If that's okay, we'll move on to the confirmation of the minutes. So I'm just looking for agreement that the minutes of the meeting on the 19th of May are an accurate record. Is everyone content with that? Okay, thank you very much indeed. So the next item is the recommendation tracker. As you know, this is a running update of all of the items of all of the overview and scrutiny committees. And there is obviously a section on health and adult social care within the document. A couple of the items that are highlighted in there are on the agenda this evening, including the health and social care for the homeless, and also the Fulfill Lives are on the agenda this evening. So is everybody happy that we just note that? Thank you very much. So we move on to public issues. So could ask the Democratic Services Officer if there are any public issues, please.
Yes, Chair. We've received one question and one statement from Chris Wakefield from Health Bath. I don't know if you'd like to come up to the table.
Yeah. So welcome, Chris. Just come and join us, and then by all means ask your question, and we'll deal with that, and then we'll deal with your statement if that's okay.
There we go. So, Chair, which would you like first, the question or the statement?
Would you like to do the question first?
Of course.
Please. Only because then I won't get confused.
Same as me then. So in relation to the agenda report on the health needs assessment for people experiencing homelessness, what is the expected timescale for completing the assessment, analysing its findings, bringing forward recommendations for any service redesign, and implementing those changes? There is a second question. Should I ask that now as well, Chair?
Yes, please.
So in the meantime, what specific interim actions will NHS Dorset and BCP Council take to address the health inequalities, barriers to accessing services, and gaps in provision identified in the report, including support for people experiencing homelessness and rough sleeping, while the assessment and any subsequent service redesign are underway?
Thank you very much for that question. So current intentions are to complete the needs assessment and to produce relative recommendations by the end of the current financial year. In the interim, individuals experiencing homelessness specifically those that are street homeless and rough sleeping, will continue to be supported by the existing array of service provision and multidisciplinary team arrangements. A summary of the operational practice of the multidisciplinary team that support people impacted by rough sleeping will be provided as part of the substantive agenda item. Would you like to give your statement, please?
Thank you very much, Chair. So the Health Bus's statement is this. Health Bus welcomes BCP Council and NH Dorset's commitment to undertake a homeless needs assessment following the September 2024 Health Watch report. We support an evidence-led, co-produced review that identifies strengths, gaps and opportunities to improve services. From our frontline experience, people experience homelessness, continue to face significant health inequalities, including poor physical and mental health, trauma, substance use, and barriers to accessing primary care. These challenges can delay treatment and increase reliance on emergency services. Our research with the University of Southampton shows that the best outcomes are achieved through trusted relationships, trauma-informed care, flexible outreach, and continuity. Ward handovers and coordinated support that addresses housing, health, and wider well-being. Health Bus is committed to supporting this assessment by contributing evidence, patient insight, and practical experience to help develop more accessible, integrated services that improve health outcomes for people experiencing homelessness. Thank you, Chair.
Thank you very much, thank you very much indeed for that. We are now going to move on to that substantive item on homeless health, and I'm going to invite Mark Harris, the Deputy Director of Place, NHS Dorset, Ben Tomlin, who's the Head of Housing Operations and Partnerships, and Sarah Reynolds, who's the Service Manager, Housing, Health and Social Care, who's also the Chair of Homeless MDT, to present this item. Who would like to go first, please?
I'll kick off. Thank you, Chair, and thank you, colleagues, for keeping this on the agenda. So obviously you've had the report that's come in. I will just go through the executive summary and then hand over to Ben and Sarah to sort of give a bit more detail around the operational side of things and how that multidisciplinary team works. So I guess it can, homelessness is a serious societal issue, and we've just heard that from the Health Bus around some of the challenges that we know faced by that population. We have done a lot of work over the last couple of years to sort of look at how we improve the offer for homeless people in the BCP conurbation and broader than BCP across Dorset and Weymouth as well. And as a result of that, we have seen some service developments. Over the last couple of years, we've continued to commission a specialist homeless GP service, which is currently provided by South Coast Medical Service. We also have a rough sleepers outreach service, which is commissioned through Dorset Healthcare, who particularly work with a primary focus on mental health, but also bring in physical health conditions as well into that. We also have a service that's offered by University Hospitals Dorset out of Bournemouth Hospital, who basically focus on trying to reintegrate people back into housing after being in hospital. Alongside that, there's obviously charitable sector sort of provision, which the Health Bus obviously are part of, along with other colleagues in the charitable sector as well. So it is a complex issue, I would say. Homelessness and homelessness health, as a result of that, brings a number of challenges with it in terms of where people present for need, but also how we respond to that in an accessible way. One of the key developments that we have put in place over the years is the development of the multidisciplinary team, which you will hear more about. And that brings together a range of professionals to look at a holistic management plan, personalised care plan for someone, to manage their presenting need, but also to think about how they achieve their best outcomes. And that includes both the health outcomes, but broader social outcomes as well, including housing. Despite that, we know from the Health Watch report from last year that things are still not quite where we would like them to be, and people are not achieving the outcomes that we would desire. So I guess what that does signal, along with the data intelligence that we have available to us, that things are not quite right in terms of the configuration of services and how they're all working together. As part of that, one of the proposals that we have put forward within our sort of partnership with BCP Council is to undertake a strategic and full health needs assessment for homeless population. Within that, we would be looking at the scale and size of the population using an agreed definition, the impact and the outcomes associated with all current commissioned services, including primary care, but also the impact and outcomes associated with local non-statutory provision as well, and the charitable sector. We really want to consider where the areas of strength are, but more importantly, where the gaps are in the current model of provision, with the idea of then using quantitative and qualitative intelligence to work with colleagues and to co-produce a model of care, if that is what is informed by the needs assessment. As you said earlier on, the intention is to complete that needs assessment by the end of this financial year, with a view then to sort of informing the strategic commissioning intentions moving forward. I'll hand over to Sarah to give a bit more detail around the multidisciplinary team working, and happy to take any questions afterwards. Thank you.
Thank you very much. Sarah, please.
Thank you. I'm going to share my screen if I can.
Sorry, before you start, someone's just emailed saying that they're having difficulty hearing, so could everyone speak up a little bit, please? Thank you.
Do my best to multitask. Hopefully you can see that. So as mentioned, I chair the Homeless MDT. The Homeless MDT has been operating for 4 years this month, and it meets on a weekly basis every Tuesday morning. I have given you a little bit of data, if I can move on. Find a way to move on. Is that me? Muted, sorry. Still doing it. I think it's when I turn this on. Does that work? No. Let me stop sharing.
It's more likely to be the sound on the laptop.
Right, I have muted that. Apologies. Right, let's start again. Okay. So, sorry, microphone now. So this is data from last year, to give you an example. So we work with quite a small cohort. Our specific focus is those experiencing rough sleeping within BCP, or a high risk of returning to rough sleeping within BCP. So last year, we had 60 people referred to the MDT, and 11 we deemed not eligible, and 49 people we were involved with last year. Breaking it down into gender, and the next slide will explain why, and age. And at the bottom, just to confuse you, just how we've collected data, 23, 24, 25 are calendar years. And then the pie chart is actually in financial year, which is why that number doesn't tally. But actually what we're seeing is a real growth in working with women. So we went from 4 in 2023 to 12 in 25, or overall in the last financial year we worked with 21 women and 28 male. And I think the age is kind of relevant because there is an age where people are at higher risk of death when rough sleeping. So it shows you the brackets of ages that we're working with and the genders of those ages. This slide here I'll explain. So we became a Making Every Adult Matter, which is meme, partner a couple of years ago. And the focus is working with people who experience multiple disadvantage. So the homeless MDT, this breakdown here, this chart here shows you of the 49 people that we worked with last year, what they were experiencing. So 49 were experiencing homelessness, and that would be rough sleeping, form of homelessness. And then you had 44 that had some substance misuse, 22 with a mental health, 11 with domestic abuse, and 26 were known to the criminal justice system, so police or probation or prison service. And then as you work your way in, so with multiple disadvantage, how we categorise that is anyone experiencing 3 or more. So as you work your way in, you'll see right in the centre, it goes all the way down to 2 people, and 2 people are experiencing all 5 forms of multiple disadvantage. What isn't on there is physical health, but I'll come on to that because it doesn't just focus on those 5 areas when we meet as an MDT. I've done a table specifically on women and homelessness. So the figures on the left-hand side are purely the women that we worked with, so 21 women. And again, as you work your way in, it shows you how many of those areas of multiple disadvantage they're experiencing. And we had 1 person experiencing, which makes 1 male, experiencing all 5 areas. What I would highlight is domestic abuse. That is a key feature that we're seeing within women experiencing rough sleeping and domestic abuse. What the data that we don't capture is any other form of abuse. So sexual violence, rape, sexual exploitation, survival sex, all of those areas, ACEs, so childhood experiences and trauma isn't captured at the moment in the data, but that is something we're looking to develop as an MDT. This chart just gives you an idea of how long we work with those people experiencing homelessness and multiple disadvantage. It gives you an idea of the average. So generally women are slightly longer than men that we're working with, but how long and the intensity. So the MDT partners, we've got around 40 different agencies linked to the MDT, and it will be representation from all those areas of multiple disadvantage as well as other areas. So we have the voluntary sector, Health Bus being one of them, statutory services, so adult social care and housing being part of that, and also we'll have representation from housing providers as well as health services. So some of the teams Mark's talked about, the hospital and outreach teams are also involved, as well as St Mungo's, our housing outreach service. This is just a case which is referred to in the report, so it's just a reminder. I do have her voice to say on an outcome. That's not her real name, but if you're happy, I'll play the voice because that gives a bit of lived experience. If it may not play actually because my volume's off. No, it won't. But there is a voice on it. Just linked to this, so we've done a lot of work with women as well around, which I've missed on the last slide, around we are part of a women's census, and we've identified that a lot of women experience rough sleeping, but they go between unsafe accommodation and rough sleeping, which is why we've partly seen an increase on the homeless MDT, because we've recognised it as an area of need within the area and work with them. The other data that we're collecting is what we call the target priority group. So this is data that housing feedback to MHCLG. And we last year had a cohort of 48 individuals that we identified in June. The category there, B1 and NR1, relate to the data returns. So the B1 would be those experiencing long-term, NR is the ones returning to rough sleeping. What we have seen and linked to the MDT, so a lot of our target priority group were people who were known to the homeless MDT. And what we've done is linked that data together to see what some of the outcomes are from a housing point of view. So we know when they started in June last year, we had 43 people experiencing rough sleeping. And then if I move to May this year, only 6% of those people are now experiencing rough sleeping. So they're either in some form of off-street accommodation, or actually the green one, which is the biggest one, 56%, they've received long-term accommodation. That gives you an idea of accommodation. What I want to say about the MDT as well is we don't just look at housing outcomes. So although it's called a homeless MDT, because we take that multiple disadvantage approach, we're very much looking holistically at their health needs, their social needs, and who can best work with that person. So who is the key agency? So although, say, for example, a voluntary sector can't give health service, they might be the agency that link them in with the relevant. So we look at, are they registered with a GP surgery? Are they going to that GP surgery? Are they working with any other, who are they working with as agencies, and how can we best meet their needs and work with them? So it's not, let's get them straight into accommodation sometimes, because that's not what they're asking for. They're actually asking for some of their physical health or their safeguarding concerns to be supported with. Building that relationship, that trauma-informed approach is what helps us to actually help them with all their outcomes and then move on. Sometimes it is accommodation that they want and working with them, and then the agency's wrapping around them within that accommodation as well. One thing I'd say we need to improve or work on is our data to evidence that, and I think the health audit will really help with that as well, and it is something we are prioritising this year to show more positive outcomes in all areas and aspects of their lives.
Ben, is there anything you wanted to add, or Sarah, is there anything more you wanted to add? Okay. Okay, thank you very much indeed for that. I'm going to take any questions that the committee might have, but could I just kick off by asking you, you mentioned at the beginning that there were 11 people not eligible. Could you just perhaps explain a bit about that, how you test eligibility?
Microphone. We have a scoring matrix that we look at, but we also, it might be that because the MDT is working so well, sometimes we get referrals in where someone actually isn't homeless or at immediate risk of homelessness. But what we'll always try and do is say, okay, what can the agencies work around that person to avoid them then becoming hopefully a future MDT. So that would be some of the reasons. The other reason might be that they've already got all the agencies involved working together. That, for me, would be the ideal future. That's how it should be, business as usual. We all work together. We shouldn't need an MDT approach, but sometimes that is happening with certain individuals. So actually, that would be the other reason. Or they're not in the BCP area would be the three main reasons. So they've left the area.
Thank you. Any questions? Councillor Dara.
Thank you. Hi, thanks for that presentation, really interesting. It's good to hear that you've identified that data collection is something that needs improving, because I'm all about the data, so it's really nice to hear that that's going to be happening. I was going to ask the same question about you about eligibility, but I was looking at the statistics that you mentioned about women's involvement with MDT. It's quite a bit longer than men, and I'm just wondering what are the reasons for that?
I think sometimes it's because actually an outreach approach isn't always the right approach with them. So they move between rough sleeping to being in unsafe accommodation. So it's being able to actually find them, I guess, in simple terms, because they're moving within that unsafe accommodation. So it's working with our partners like the police, our CSAS team, people like that, to see where are they seen, and then how can we work with them, which agencies are seeing them. So sometimes, and the case example that's giving in the health audit paper, she was an example of someone that just wasn't being seen for a long time because she kept moving in and out of different unsafe accommodation. But eventually there was a crisis point that hit, and she was seen, and that agencies wrapped around her very quickly. And within 2 weeks. She was in long-term accommodation, has been seen by the GP, health bus were involved, had seen the hospital team around her Hep C. She was scripted by the scripted by the Drug and Alcohol Service and seen by the safeguarding social worker around the concerns around domestic abuse. So something like that can happen really, really quickly, but it's finding someone.
Thank you. And following on to that, and I think it probably links into what you just said, because I read somewhere about the data for homeless women is probably underestimated, because homeless women, because they're more vulnerable or feel more vulnerable, they tend to hide. So they'll be sitting on buses or night buses or sitting on trains, or they'll be hiding in the toilets. So how are you able to make sure that those women are identified?
Yeah, we take part annually, and it'll be the 4th year this year, in the Women's Census in September. So again, a lot of the MDT partners take part in that. It's led by women, so it is women that go out. But we've changed the approach. So whereas it initially used to just be on outreach, we recognise that specifically around women. So actually, utilising a lot of the services, the voluntary services, where the people can go and get food, the hospitals, going down to somewhere like I was going to say McDonald's, but it's not McDonald's. Greg's is quite popular. Utilising those places, that's where it's brought women into contact. So a lot of us would go out on outreach into, say, the homeless food providers, and that's where we're finding them. So I think the Women's Census has seen an increase, which has had a knock-on effect with the homeless MDT and the referrals.
That's great, because it's good to hear that you've actually identified that and you're working to, and that's why the number is increasing, because you're identifying them more. It's great, thank you.
We also work closely, I was going to say, just with Dorset Working Women's Project as well. So recognition around with Dorset Healthcare, the women vulnerable because of sex working.
It may be useful just to add that evidence base has been really helpful to us in informing what we commission. So we're 4 years into that work in terms of more intensive data collection around the housing needs of women. 2 years ago, we identified this additional need and commissioned a bespoke supported housing service specifically for women with multiple disadvantage. So we've commissioned a service, successful with some capital and revenue grant as a council to provide that service, and it's now really successful in providing off the street accommodation and longer term settled housing options specifically for women with multiple disadvantage, and it's won awards, so really successful.
Thanks, Ben. So we started on this journey end of last year, really on the back of the Health Watch report, and Louise Bate from Health Watch is online, has got a hand up. So I'm going to take Louise at this point.
Thank you, Chair. It's really good to hear about the work of the MDT, and I really welcome this health needs assessment. I was thinking when I looked at the paper how the case study really brought it all to life, and I think in our reports too, it's often the case studies and the stories that kind of really really capture people's voices and their lived experience. So it was an offer. If you need case studies for the health assessment, or if there's any way in which we can help kind of bring that lived experience to the assessment, we'd be happy to help.
Thank you. Thanks, Louise. Any other questions from anybody on the committee? Any final thoughts? I think I'm going to come to the recommendation shortly, but Councillor Richardson.
Yes, apologies now if I miss this, but how does the referral process, how does it all come to your attention?
It's through any of the agency partners. So we get, probably the majority come from St Mungo's, our outreach service, but on the whole, it can come from any of the partner agencies.
Who would be the sort of main agent? St Mungo's, I know, but who else is there?
St Mungo's, housing, adult social care, and we have a homeless intervention team that would refer in as well. Dorset Healthcare. So we get some from the Homeless Health Service, the hospital team, so Health Bus, Dorset Working Women's Project. I can go on, there's a lot of agencies. But yeah, it comes from any source within that partnership.
Thank you. Are the police involved in that process at all, Sarah?
They are, yeah. We haven't got a rep at the moment because we've had someone change jobs, but we are working with the police to have a new rep back on. So yes, they're very much
part and parcel of the MDT work.
Yeah.
Okay, thank you very much. So the recommendation is to note the current progress to date and planned work to undertake a homeless health needs assessment as a means of informing future service redesign where indicated. So I'm going to take that as a recommendation, see if everybody's content with that. But I think in doing so, I think probably be looking to colleagues once that assessment has been done and you're in a position to tell us something of what that's telling you in terms of how you're going to respond to that in terms of commissioning services. I'm sure committee would be really pleased to hear that in the future if that's possible. Any kind of timescale that you might be able to help us with?
So I guess it's difficult at the moment because there's lots of organisational change going on in the ICB. But I think what we're trying to commit to is to have that full assessment completed by the end of March. And at that point, then it will be able to it will inform any commissioning intentions. So I think if we come back at the beginning of the next financial year with an update of what that needs assessment has told us, what the next actions are, and a timescale around how we might go about any changes to service provision, if that's acceptable to the committee. Thanks.
Okay, thank you very much. So can I take your agreement if that recommendation is accepted, please? Everybody happy with that? Well, thank you very much indeed for that. Thank you for everybody who's come to contribute to this discussion. I'm going to take a slight short break, which was your opportunity to leave if you wish to. Okay, thanks everybody. We'll press on to the next item. Can I just ask, if you speak, can you just bring this device a little bit closer to you, because online people are struggling to hear, and it helps a little bit if the microphone's a little bit closer to you. But don't take it home with you, please. So I'm going to move on to the Learning Disability Big Plan. Welcome to those who have joined us. Very great pleasure to welcome Amanda Frost and Bridget Campbell from the Learning Disability Partnership Board. I guess I should declare an interest at this point to say that I am a member of the Learning Disability Partnership Board. But there you go. And a welcome to Councillor Allen, who's joined us. So thanks Hazel for coming. So without any further ado, I'm going to invite Amanda and Bridget to give us their presentation, please.
Hello, I'm a Big Plan Learning Disability Strategy for 2026 to 2031. Hello, I'm Amanda Frost, co-chair of the Partnership Board and Assistant Manager of the wonderful People First Forum, a speaking up group for adults with learning disabilities in the lovely PCP area. Introduce myself. Co-chair of the board, and at the moment I do Oliver McGowan. I'm trained. I'm tier 1, tier 2 trainer.
It's hard to follow that. My name's Bridget Campbell. I am a family carer of a man with a learning disability who lives in Poole. As the chair said, I am also on the Learning Disability Partnership Board and various of the action groups as well. And both Amanda and I have been part of the Big Plan project group, which has been helping to put this
memorial
together.
Yes. Both last plan and this one.
Yes, yeah. We've both been around for a while. Yeah. Okay.
So you're going to take us through the presentation? Thank you.
Introduction. This plan builds on all the good work from the last big plan for people with learning disabilities. The big plan has 7 big aims. The Learning Disability Partnership Board oversees the plan. 4 action groups led work on 4 of the big aims and helped turn the aims into action. To help develop this plan, we asked the health action groups what has been achieved and what work are we continue to doing. You know, like call it something business as usual in our broad term, innit? The 7 big aims are like what Sarah was just been is chair of, and the 7 big aims: where I live group, staying healthy, having a good life, the right care support, keeping safe, becoming an adult, support from my family, what lovely Bridget and all her carers, family carers look after. And in the middle, there's person, there's the person centred, the person with learning disability in the centre of it all. Engagement and survey. People with learning disabilities and family carers have been at the heart of the discussions and consultations since the beginning of this work. The Learning Disability Partnership Board held discussions and workshops to suggest the idea of what new work we wanted to do. I mean, you know, weren't you, Chair? You were involved too. We then took these new ideas to the 3 engagement events across Bournemouth, Christchurch and Poole. Bournemouth at the Life Centre Moordown, Christchurch Connect and the Poole Spire. And we spoke to then 150 people. The results were shared with the Ladies Partnership Board, who held further discussions to shape the draft plan. Action groups reviewed the feedback and priorities for their big aim. A public survey was launched in early 2026 on the proposed new work. A powerful video, what had me in it, sorry to say, was used to promote the survey and reach thousands of people through social media.
So the survey outcome. 97 responses were received, 41 online, 56 on paper. People made lots of comments on the survey, and this feedback was reviewed by the project planning group, the Learning Disability Partnership Board, and the action groups for some of the big aims. The main themes that came out are in the papers that you received in preparation for the meeting. So on page 4, the key themes that came out are listed there. The partnership board asked the project planning group to review these key themes from the feedback and develop headline actions, which you have also received in Appendix 1. The next steps are that the 4 action groups, so that is covering the Where I Live group, Staying Healthy, Health Action Group, and the Carers Action Group, so that's 4 of the big aims, will develop detailed delivery plans for their particular big aim. The Learning Disability Big Plan, if you recommend it to go forward, will be presented to Cabinet on the 2nd of September this year. And the project group will review the 3 big aims that do not currently have action groups and agree how these will be delivered. 2 of those big aims are mentioned in the paperwork you've had: the right care and support when I need it, and having a good life. The 3rd one that actually isn't down there is the preparing for adulthood one, which I think there are potentially other ideas about how that might be taken forward through the Preparing for Adulthood board. I'm not sure whether that's been agreed yet. And then we hope very quickly to start putting the big plan into action through those action groups and the Learning Disability Partnership Board monitoring how those go. Are there any questions?
Are there any questions? And can we answer them? Look enough Siobhan's here and Tim.
So looking to the team, is there anything you'd like to add to what's been said in terms of the next steps particularly?
I think just to add to what Bridget was saying, obviously the next steps for us are going back to the action groups, have responsibility for each of those big aims, setting out a delivery plan with timescales, and then that's the delivery plan that the Learning Disability Partnership Board monitors to ensure that there's movement forward on all of those actions. Bridget mentioned preparing for adulthood, which is obviously a very important group because that's around young people transitioning from children's services into adult services. We do have a strategic group, which is a combination of adults and children coming together to deliver. So we will be having conversations with them about how they can support us to deliver that particular group. So next steps are very much about the structure and governance and starting to deliver against the strategy.
With Health Action Group, you know, with Mark and all who he works for being a bit disarray in it, not knowing how the jobs are, but me and Louise Bate and a few people and the board via the Health Action Group wrote a letter to all them on the hub, and we've yet to know in autumn or whatever. We had a thanks, and they said, "Oh, the group looks fantastic," but they won't know till the autumn, so we'll have to keep us watch it peeled. That's how it is with that one particular one, but we're up to all here, don't we?
Thank you. Any questions? Any from Councillor?
How do residents with learning disabilities find out about the boards and things?
A few. We have a few at our committee, and myself come to the light board, and we see about all the board, because I think all this Bill of Rights and all how we work, is when we have our things in our work, that it's all them topics each month, having a good life, you know, looking at all, and then our speaking ups and all our work and our speaking up groups, cover, and when we speak to people how their health is, are they living well, is transport thing
I think
great or
Siobhan,
bad? Yeah.
thanks, Amanda. I think Siobhan might help as well.
Just to add to that, BCP Council do fund People's First Forum.
Okay.
We ask
Uh,
them to represent.
Siobhan, can't hear you.
Green. Let's
Oh, gone green now. Okay, sorry about that. So BCP Council do fund People First Forum, where we ask them to go out, and they do sessions out in different areas of the community to try and draw people into the forum, and then obviously from there they can become engaged if they choose to with the Learning Disability Partnership Board. We also have a carers support worker, so carers can actually engage with that support worker. They have their own group, but then they have an opportunity from that group if they want to join the board as well, and then feedback. So we try to make sure that those who want to be part of the board can be, those who don't feel at that time that it's the right place for them can still engage with the board through both People First Forum and the Care of Support Worker.
So do housing officers, if they go round to properties in BCP, do they give information out about the boards and the, you know, where people can get help, whether they're carers or with learning difficulties? Or do we not use our officers?
So I couldn't speak on behalf of housing in terms of what information they give out. What I can say is Sarah Reynolds, who represented today, is the co-chair of the Where I Live group. So housing and social care and all our advocates and carers come together to discuss all the housing need. And then from there, they would share that any information and make decisions about how we develop information as well. So that's part of this, is information and advice and how people can access it. So there's a partnership between the two to make sure that information is available to people as they need it in different forums, etc.
And I think it's fair to say, Tim, isn't it, that we've looked at what housing support this particular group needs, you know, a kind of assessment, as it were.
Yes, so Housing Led partnered with Children's and Adults on a specialist housing strategy. And that's now been published. I think it came before the over in Scrutiny. So that's actually identified the needs and the housing needs moving forward till 2035. So for learning disabilities, it's been identified that we're going to need an extra 165 units of accommodation for people with learning disabilities up to 2035, which is about 16 a year. So this year we're on target to meet that. And obviously we're working with our housing colleagues to look at how we develop future accommodation, which is their role, and obviously our role in health and social care in partnership with the Where I Live group is then to say, okay, how do we translate those units into, you know, what type of housing and what type of support are needed. So there's an actual connection between obviously the work that the housing and social care are doing and the big plan.
Any other questions at all? Right, I'm going to move on then to the recommendation, which is that the committee request Cabinet to approve the Learning Disability Big Plan for future publication and delivery against the priorities set within. Is everybody content to accept that recommendation, please? Thank you very much indeed. And I'm not pushing you out, but if you want to take this opportunity to leave. That's too much information. Right, thank you very much, colleagues. So we're going to move on to the Fulfil Lives programme update. And at this point, I'm going to invite Tim Branson to present this item, please.
Okay, thank you, Chair. And good evening, members. I'm just going to share a short presentation. I'm taking it that obviously everybody's had plenty of time to look through the paper, so I don't want to labour too many points. Excuse me a moment. I'm just going to stop showing that one. Make sure I've got the right one for you. I think this is the right one. There we are. So I'm just literally going to highlight a few of the points from the paper, and then obviously if anybody has any questions, more than happy to take those. So quick reminder, this is our 4-year transformation programme, which we had funding agreed and funding for the investment agreed in July of 2024, and then we moved into the sort of delivery phase of the programme from January 2025. So as I say, we've had the full investment for the programme. Pleased to say that for the 2025-2026 financial year, we managed to achieve the savings target in full. And you can see here, obviously, we have a very similar savings target to achieve in the current financial year. And the objective is to achieve a recurrent annual saving by the end of the programme in 2028 of £3.5 million. So the programme currently is within budget, and we're still seeing some service improvements continuing, and you'll see there's some feedback from individuals who have experienced some of the improvements that we've been making as an appendix to the report. As I think we might have mentioned before, we have experienced some challenges in terms of timing for some of the financial benefits. A lot of that has been to do with issues outside of our control. So as an example here, our IT system supplier has needed to make some upgrades to the system from their end. That has meant that some of the changes that we would want to implement from our end have had to be just paused for a while because there's a change freeze. It's very technical. I wouldn't profess to know all the ins and outs of it. Needless to say, it just means that some of the benefits that we would like to see have just been sort of delayed by a short, probably about sort of 6 months or so. But as I said, we're expecting, in combination with the 4 projects, that we will certainly achieve the projected savings by the end of the programme. And this is just a quick reminder of the 4 projects. I've shown this slide plenty of times, so I probably don't need to dwell on it, but just as a reminder of the 4 component projects within the programme. And obviously it's the fact that they all interact with one another that will bring about the overall benefits at the end. So I'm just literally taking one slide for each of the projects, and just to highlight a couple of the sort of key points really. So 3 Conversations was a model that we've implemented now across all of our operational teams. The focus now for us is on embedding that sort of practice, because it is quite a major shift in culture and mindset, I think, for our practitioners. Linked to that is making sure, and I'll talk about it on a slightly later slide as well, but linked to that is our requirement really to try and make sure that as many people as possible, when they're coming through our adult social care hub, actually get connected to some short-term support in the first instance. And what we are seeing and have continued to see is that all those new requests that traditionally were converting into long-term services, that conversion rate is improving now, so that we're actually seeing fewer people coming through who actually then need that long-term support. So that'll be a combination of a 3 Conversations approach and the fact that we've introduced some short-term support in the first instance, and that has removed the need for the longer term care. The fact that we've got the 3 Conversations approach, I think, has certainly been recognised by Care Quality Commission when they visited us last year, and I'll be talking about that later as well. But you'll see just a quote from the report that we received recently, which kind of recognised the fact that, you know, those improvements were really starting to bear fruit. In terms of self-directed support, continuing to make really good progress in terms of our community micro-enterprise developments. So we've now established 11 community micro-enterprises. We've got another 17 that are currently going through the programme of accreditation. And I would expect that to continue, I think, in other areas where you suddenly get a sort of a tipping point where the momentum really starts to sort of build. So I'm very optimistic that, you know, we're on the roll with that now. And we've also just started some work on our direct payments improvement programme. So again, recognising that direct payments are a really good way of people being able to kind of take control and have that sort of freedom of being able to sort of choose how their care and support is delivered. But we've also picked up through quite a bit of consultation with people that you know, sometimes they're not the easiest thing to manage. So so we're definitely working with people who receive direct payments and our own staff to make sure that we can make that as simple and as effective a process as possible, so that people can really reap the benefits of it. Also, just a quick statistic on the side there in terms of direct payments for carers specifically. You'll see that we've been putting a lot of effort in the last sort of year or so into improving the number of carers who access a direct payment in order to shape the support that they benefit from and that they need. So that's gone from 7.5% to a massive 75%. So we're really pleased with the way that that's gone. That's partly because we reshaped the way that we provide services through traditionally what we were doing through a voucher service, and actually we were getting quite a lot of feedback from carers that the vouchers weren't working for them, and actually substituting a direct payment was the obvious thing to do, and that really has made the difference. In terms of the better short-term support, so this really links back to the comment I was making earlier about sort of people accessing reablement, and particularly the community reablement pilot, which is what we've been piloting through the transformation programme. So distinct from people accessing reablement as a pathway out of hospital. Again, we're just coming to the end of the 12-month pilot, so evaluation will be starting in earnest anytime now. But you'll see some early indications of the sort of benefits and outcomes that we've had people finding, really, with a good 50% fully regaining independence, so literally no need for ongoing support beyond the intervention from the reablement service. And then lastly, the support at home project, which is effectively all about how we create a new all-age home care framework. And that's gone through a process of procurement at the moment, with the tender closing in April. Evaluations were conducted through May and June, and we're literally just in the process of awarding contracts for that tender. With an expectation then of mobilising those contracts by October. And again, a very positive response, I think, from the market in terms of the number of bids that we've received for both lots. And then the plan is separately to then have a specialist sort of complex care framework, which will be commissioned separately, which Siobhan it's okay, it's out now, I'm told. So so that's going ahead as well. And lastly, as I said, I think earlier, the appendices in the report highlight 3 more examples of where the work that we're doing is having a really good impact. I think the first example actually relates very much to the earlier item we had on homelessness, because actually that was our homeless intervention team that was actually involved with Miss P. And then this is just to close off, really, just explain what we're focusing on really for the next 6 months about embedding the 3 conversations approach, In terms of the hub, we're really wanting to maximise the way now that we're working with our telephony system. We were having some conversations with IT colleagues only the other week about how we can improve the way that calls come through, so that actually people don't have to wait for a response for as long as they might have been otherwise. The direct payments work obviously will be going ahead, and that's all about sort of simplifying the process, as I mentioned earlier, and evaluation of the community reablement pilot, and obviously the support at home contracts mobilising in time for October. So I think that was all I needed to say. I'm more than happy to take any questions.
Councillor Down.
Thank you, Chair. I'm going to have to move this to this point. Thank you for that. It's really interesting. I wanted the amazing work about the 7.5% to 75.88%. That's really good. But what did sort of make me jaw a little bit was the change freeze that you've got with your IT supplier. And have they actually put a 6 months change freeze on what's happening?
Yes, they have. It's as I say, it is quite technical. So IT colleagues would probably be able to explain it a lot better than I would. So we did have plenty of notice of the fact that there was going to be a change freeze.
Right.
So it hasn't. So there were quite a lot of changes that we've already made in advance of the change freeze. So the remaining changes that we need to make are probably the tail end ones that aren't so critical. But what we're finding as we're going through this whole process is a constant sort of process of refinement.
Yeah.
So some of the changes that we've implemented around the 3 conversations approach and making sure that the IT system works alongside that properly, where we've realised that we probably need to make some slight refinements to the kind of practice, then there's a few further changes that we need to make to the system to make sure that that sort of fits with it. Some of those may just have to wait for a few more months before we can sort of find it. It doesn't stop the practice, but it just makes it a little bit more complicated for a few months.
Okay, so I'm hearing that the testing, identifying sort of bugs and changes and things that you have to go.
Yeah, correct.
So that's good. But so if you're saying that they actually gave you notice of it, I was going to ask, my follow-up question was going to be, is there any penalty they're going to be hit with for not meeting their targets? But it sounds like that was already agreed up front.
Yeah, no, that was all absolutely. Yeah,
okay.
That was all part and parcel of the agreements.
Thank you.
Yeah.
Chair, do you have another question, if that's all right?
Carry on then.
Thank you. It's about the procurement milestone. And you said you've got a lot of bids in, which is really good. And so this is for the home contracts.
Yes.
So when you've actually selected the supplier, how are you going to measure success and make sure that they're meeting the quality standards that you want? And what would be the process for sort of making sure that that does happen? And if it isn't happening, what's going to be done about it? So what's the break clause, so to speak?
Thank you. Yes, it's not one provider; it's a framework of providers. So they obviously have to pass through the procurement process, and then within the contract, we have heavily contract management of every provider that gets through on the framework. There's robust KPIs in the specifications, and we have a service improvement team as well that goes out. So there's 3 sort of strands to monitoring the quality. We do pride ourselves. We have a really good quality care market. So we wouldn't want to lose any of those standards. So yes, that's the procurement. It's a framework of providers that we then use to call off when we have the requests come through for home care.
Perfect. Thank you.
Thank you. Can I just follow that up? So you've got this framework, and you've got the demand for home care. How do you allocate the people demanding the service or asking for the service to the provider? Is it geographical? Is it just capacity? Is it some kind of speciality? How does it actually work?
So that's through our care brokerage team. So within adult social care commissioning, and then they obviously take the requests through our mosaic system through the for the social workers. Then they're processed within the team. That then gets sent out. That request would get sent out to our providers that we know have capacity. So every week, our providers fill out a capacity. It's a tool, a national tool around the capacity within their care home and their home care provider. So they would look, our brokerage team look what services, what providers have got capacity, and then they approach them and they offer those referrals go out, and then then they come in and which ones can accept that referral. Quite complicated.
Sounds easy. There is not.
It's a broker, so they're brokering.
Thank you very much. To the question that Councillor Bagwell.
I love that, you know, showing us all the bits. Really simple, really good. Loved it. The direct payments can be very difficult for some of our customers. So do we make sure that, like, I know if I gave my daughter, for instance, a lot of money, she would just spend it on whatever she wanted, not necessarily where it needed to go. So do we make sure that people don't fall through the holes? Brilliant, thank you.
Yes, we do. So we have a direct payment support service, and most people these days tend to take their direct payment in the form of a payment card, which is a bit like an online bank account. So that's set up specifically for the money that we give to them as part of their personal budget. That money gets paid into that account. We actually have a way of monitoring all of the expenditure on that account. And it's done that way because previously, before we had that sort of functionality, people had to keep their receipts and they had to send in a return at the end of each year. So it became more of a, you know, an onerous kind of process for people. Having that online option, which, as I say, most people prefer. We still have the option of the paper version if people would prefer it. So we don't, you know, we give people the choice, but most people choose the card. That makes it a lot easier for them, and it means that we can keep a track more or less on an ongoing basis to see how they're doing, really.
Thank you ever so much. Can I ask a couple more questions? Thank you. What was I going to say? The vouchers going and being changed for the direct. Sorry.
Yeah, mine did that as well.
I beat it. Well, that's green as well. Did you take yours off? Thank you. The vouchers have been changed them to the payments as well. That sounds really good. Much better. Everybody is moaning to me about vouchers. The other thing was the intervention. When people go through it, are they able to jump back on it if something happens and they need to go back onto for intervention team to help them? Or once they've gone through the intervention and been helped, do they then have to start from the beginning, or, you know, can they just jump back on?
Are you referring to the homeless intervention team? Sorry, yeah. Yes, absolutely. So if there was a need to get re-involved, then we can get involved again.
Wow.
Yeah.
I like this. You've done it. Thank you. That's really good. I am well impressed. I am. Takes a lot to impress me as well. The other thing, just finally, is the complex case network. That is amazing. My daughter had complex issues and it was so difficult because nobody understood. So that is brilliant. I love hearing that. Thank you.
Thank you for the report and for the presentation. It's really good to see that you've got 11 micro providers and 17 in train. What's the balance? Are you getting the providers in a sort of similar, you know, offer, or are you getting a nice broad offer that means that actually you're really able to offer some really interesting?
I'd actually from the link actually. So that there are a number that
She's green as well. Oh, it's my
There we go. So there are a lot that are companions. So allowing people to be supported to do whatever activity they want to do. So Mrs. Y was a classic example where it was very much driven by what do I need in the week, and that can be shopping, going for walks, etc. We have a fishing for well-being. We have, I was just looking actually, we've also got somebody who's doing tech assists for older people to help them to learn how to use technology. We've got fitness groups, we've got nature well-being, so that there's quite a variety. One of the things that we do and we're continuing to do is go out and do a bit of co-production with the community and say what it is that you want. And then we're going back to the community catalyst and saying, can you put out adverts and keep looking for those different types of activities so we can kind of plug the gaps. So it's a continual learning and reflection about what we've already got and where the gaps are and can we find people. But obviously it's driven by individuals who want to do it and what skill base that they're bringing forward.
I picked up on the IT thing as well. So if you don't reach your target because of the failure of an external provider, I know you say they gave you plenty of warning, but that doesn't sound great. So I just wonder, how does that put you in a position with regards to the excellent work you're doing? Thank you.
Thanks. So just to reassure you, it won't impact on the savings target because of as I say, we can still practice the way that we need to practice. This is just really more about how we can support our practitioners to be a little bit more slick in the way that they're recording the work they do, but it doesn't, in terms of the person's experience and our interaction with the person, it doesn't actually impact on that at all.
So with regards to the reablement pilot, I don't like the word pilot. I like to see things continue, especially with the results that you're getting. And as you know, I'm really passionate about reablement because I do think that if you, I mean, your 3 conversations, you're getting to people quickly and giving them some initial options and advice so that they can proactively get on with some change straight away, so that then hopefully they don't end up with more care needs later on. And reablement, they all just go hand in hand with you know, I love saving money, but actually what I think you're doing is just providing a much more person-centered approach. So what's the chances of this reablement becoming a permanent situation and not just a pilot? Because I don't like pilots because there's always potentially a bit of a lag after the pilot. Everyone says it's great, but then you don't necessarily have the funding or structure in place.
Yeah, it was a pilot for a reason, because we wanted to understand what the take up would be, and whether, although our practitioners were crying out for the service, because most of the current provision we had was associated with hospital discharge, so we wanted a specialist dedicated service, and we wanted to make sure that the take up was high enough from community teams. That has been a challenge, surprisingly enough,
Right.
because the referrals that are coming through to our community teams are mainly for people with long-term sort of conditions, and the sort of some of the argument is that actually this person can't be reabled. So I think there's some work we need to do with our practitioners about that sort of understanding, because I'm like you, I think everyone should have an opportunity to be reabled, even though whether it's to full independence or just a bit about what they want to improve on in their condition. So we still need to do some of that work, really. So we'll be sort of looking to extend the pilot, I'm afraid, until we've got the uptake we can justify then the value for money of then having it a permanent service.
Yeah, I can sort of I can see that, and I think with any new service or concept, even, it's just for people to start to really understand who that is going to genuinely benefit, and then even if that is done at a lower level, as long as it's showing to be effective. And what I write down there, and I can't even read my own writing now. Oh, so it was interesting your question to from the chair about how do people get you know, allocated, or it might not have been your question. I stayed up to watch the World Cup last night, and I'm just so tired. The sort of the answer to that broker, and you put out a tender and some, that feels a little bit provider led. It could have been your answer, but it felt a bit it was almost like, can anyone catch this? Is there anybody out there that can catch? Rather than, I probably would have liked an answer that was like, oh, and we try and match the provider to. I know that that might not be the reality, but I just wondered if you could expand a bit. Thank you.
Yeah, of course. Yeah, probably was a bit flippant. I didn't mean it like that. I meant that it depends what capacity, because obviously they're generally morning, lunchtime, and evening calls. So someone might want a tea time call, but actually the provider's only got a morning call, and depending where that person lives, etc., and whether sometimes we do get, obviously people only want female carers. So there is a lots of matching in the background, but it's the nuances of that. So the process is still that process, that the referral from the practitioner with some of those choices and preferences goes into our brokerage team, and that the brokerage then act as that interlink with our providers, who it's only there's it's not an everlasting list. It's a relatively smaller number of providers on our frame list, because they have to jump through quite a few strict hoops to become one of our framework providers. That's why we opened it up again, because we had quite a lot of providers wanting to come onto our framework.
Add on the complex one as well.
Oh, yeah, and also, so sorry, just in addition to that, we've also added in a lot that was in Siobhan's disabilities, which was a specialist lot, actually. So for an adult with a learning disability, they need home care. It really didn't, it's a provider regardless. So it's all ages, where before it just used to be 65 plus. So we've now done it all age. So they get a standardised fair service, depending it doesn't matter what client group you're from, it's still a fair equitable service. So that's a slight difference as well. I don't even want to add any more to
yeah, I suppose just to say, because obviously there's two frameworks. So the framework that Zina's mentioned, but then there's the complex disabilities framework, which is very much focused on learning disability, autism and mental health. So where we have much more complex needs, whether they're forensic, behaviours that challenge, complex health, they're in that framework, and that very much is about we've got different lots that kind of denote the different types of services. So there is a much more focused approach to that, and working with providers to make sure we get the right provider to support those people. So you've got the more generic all age, and then you've got the more specialist, so where we do have very vulnerable adults, where we need to really look for very specialist providers with high levels of skills around mental health, offending behaviour, etc. We've got a more bespoke set of providers for that.
Yeah, and yeah, I didn't mean to be critical. I just guess it's, it is what it is, isn't it? You haven't got hundreds of providers offering you everything, and everyone's got to is going to get a completely bespoke offer. But it sounds like at least you've sort of considered their requests and their needs prior to going out to the providers, and so thank you. That was just interested to have a bit more detail. Thank you.
Thank you. So with the card system, so people will be able to get X amount of support for Y number of hours, presumably. So what's the process if they say, do you know what, this isn't really working for me? How do they change that arrangement, if you understand what I'm saying?
Just to be, so you're talking about the direct payments card? Yeah. Okay. So if somebody's got and bearing in mind most people tend to use their direct payment card for something other than domiciliary care, because we're able to provide that anyway. So occasionally somebody might use their direct payment for a provider that we don't have a contract with, but more often than not, then those direct payments will be used for other things, principally alternatives to day opportunities. So they might purchase support from a community micro enterprise, for instance, with their direct payments. So some of the things that Siobhan was just saying in terms of the way that somebody may like to spend their day, actually they would be using their direct payment and they could use their card to pay for that. Sometimes it might be purchasing items that they need, to support them, that type of thing.
I don't think that's what you.
Go on.
No, I think were you asking, Chair, that if someone didn't want to have a direct payment anymore, they could then go to a commission service if they change their mind. They can change their minds. Yes.
Yes, I'm just going to get back onto my old concern. One of your conversations in the information you've given is a lady who was not in suitable housing and was moved out, which has always been my chief concern. So how are plans to deal with that sort of situation? I mean, she's actually said, "I'll never forget what you've done for me. I was dying in there."
Yeah, so that was a lady who was supported through our homeless intervention team. So her in the way that we were hearing earlier, she was brought to our attention through that multidisciplinary working. So obviously, once we were aware of her predicament and the fact that she needed an intervention from not only from a safeguarding perspective because of the company that had people that had latched on to her and were exploiting her, but also the fact that her housing was of a unsuitable standard for the health needs that she had, and therefore working in that sort of combined way, we were ensuring that she got all the right support and made the case for her to be accommodated in more appropriate housing. So I don't know if that's answered your question, but
Yes, it does, but is a thorough assessment carried out, and is there housing available if people need to move?
so we will conduct our assessment under the Care Act to make sure that all the social care needs are met, and then colleagues, obviously from a housing perspective, will undertake their housing needs assessment. And we, as I say, because we work jointly, then all of those different perspectives are brought together to make sure that the outcomes for the individual are obviously what's needed.
I think there might be quite a few people in that situation.
So on the question of the community micro enterprises, so I'd really just like to be a bit kind of clearer about how that process works. So you've got this directory of people who you know can provide whatever they can provide. So is BCP paying them for any part of that offer, or are they reliant on monies depending on the the residents who want to take that service? If you understand what I'm asking.
So there's two elements to the community micro enterprises. There's the community catalyst, which is the provider that goes out and advertises for, works with them to ensure they're a sound business, and then does the accreditation process. That's a contract that commissioning holds to ensure that that's carried out appropriately. If the person is then eligible, we're mostly working with through our direct payments. So a person will receive a direct payment and then they use that money in order to purchase from the community micro enterprise. We can, of course, directly commission if that's their preferred option as well. And that comes out of the operational social care budget against that individual's assessment.
So if you realised that you had a range of different people asking for the same service, could you then commission that service to provide it for more than one person?
So the community micro enterprises can take multiple people within their diary. We could commission the services, but they actually come out much more expensive if we commission them. And if you start to get larger services, we start to be affected by different VAT rules, which then increase the cost even more. And that then gets passed on to the direct payment. So what we're trying to do is work with much smaller providers, which are much more cost effective, both for us in terms of a direct payment, but also if you're a self-funder at any point, obviously it's much cheaper for a self-funder, because we're obviously encouraging them to use those services as well to try and prevent them from having to enter into longer term social care. So it's a much more cost effective and a more personalised service by keeping it small, but they can take multiple people. If they fill up, then absolutely we'd be talking to Community Catalyst to say, are there opportunities to develop the same sort of service? Are there other people out there that could deliver that for them?
Okay, thank you. I did ask my Member of Parliament about releasing VAT from health, but you know, that's a whole different story, isn't it? Councillor Dower.
Thank you, Chair. So this is probably me being a bit dim. So this card that our customers could use, is there a possibility that they could be misused, as in the vulnerable person with the card could be paying somebody who was taking advantage or scamming them? Is that a possibility? I'm not really 100% sure how the card works, really. I think that's the thing.
So when people have the card, we are able to monitor all of the transactions that they make, so we can see where they're being spent. We can quite easily spot if there's any unusual looking transactions relative to the care and support plan. So all of the direct payment the direct payments that are made to individuals are based on their care and support plan of their eligible needs. So their card needs to be used to purchase the type of care and support that has been identified on their care plan. So if we start to see some transactions that don't equate with what we would expect to see based on what we know of their care plan, then that would trigger some alert that we would need to make sure that they were spending it appropriately.
Good. Thank you.
Okay, any further questions, anybody? Okay, thank you. So the recommendation on this is that the committee notes the current work in progress with the Adult Social Care for Full Lives programme. Everybody consent with that? Thank you. So we're moving on then to item 10, which is the outcome of the CQC assurance visit, and I persuaded Tim to give us a verbal update. So over to you, Tim.
Yep, thank you. Okay, so as you'll probably remember, we've had an assessment of our compatibility with the Care Act 2014. So the Care Quality Commission have been undertaking benchmark assessments of all local authorities across the UK. That process involved us submitting our own self-assessment of where we felt our performance was, and then CQC would also access publicly available data that we report through sort of national reporting channels. And then in December last year, CQC actually had a small team who visited the council and the area, spent time talking to staff and residents, our system partners, carers, and on the basis of that, they undertook their assessment and reported back to us in June. Was it May? Just trying to think. We had it in June, wasn't it? So we had our report in June, and the outcome of the report was that we were considered to be that we required improvement. We scored 56% on our scoring, which basically equates to that requires improvement. We were literally 7 points away from a good outcome, which was rather frustrating and certainly not what we were working towards. However, the strengths and certainly the key strengths that we were that were recognised within the report was that we actually scored very highly in terms of our safeguarding and our leadership. So two of the key domains, which when we've just recently seen a report from CQC around their summary of all of the themes of the inspections that they've done, actually they mentioned the fact that a lot of councils were actually struggling with their safeguarding. So it was really pleasing to see that we were actually doing well on that regard. There are another number of other sort of strengths that were sort of pulled out from the report. So the fact that we had that strong prevention and early intervention approach, and again, as I think I mentioned earlier, they recognised the fact that we've been implementing our transformation programme and felt that that was absolutely the right path that we were on there. So it showed that we had that sort of consistent strengths-based approach and very sort of person-centred practice. And that we'd made quite a lot of improvement in terms of the waiting times for people that needed an assessment, and as I said before, very strong sort of positive safeguarding performance. Again, they recognise the fact that we've done a lot of work around sort of market shaping and innovation, and the work that we've done to sort of really develop our workforce culture and that sort of multi-agency safeguarding approach. And I think one of the big things that we've achieved over the last sort of couple of years really is getting a better handle on our data. So we've got sort of much more sort of real-time data information, sort of dashboards, and that really helps us to kind of from a governance and oversight sort of point of view, to make sure that we're making the right decisions in a timely way. That said, there were obviously some areas that we need to focus on that were identified, and again, I think whilst we were disappointed, I think to receive that sort of outcome initially, because clearly it wasn't what we were aiming for. I think on balance, we recognised that it was a fair and balanced report, and I guess there weren't really any surprises in there. So I think it was reassuring that we know ourselves quite well, and I think that's because of the data that we've now got at our disposal. So there were some issues around sort of consistency was one theme that sort of came up. So although there was a lot of that sort of strong practice, it wasn't necessarily being seen consistently across everywhere. So that was one of the things that we need to do. We need to sort of strengthen the accessibility and the equity around certain areas where it's been a challenge. So interpreters, for instance, was one thing that was mentioned, and advocacy was another. But we need to now just demonstrate that the improvements we've made, particularly around sort of waiting times, that we can actually sustain that, because most of those improvements have been relatively recent. And I think, in fairness, CQC like to sort of make sure that it's not a short-lived thing and that we can actually sort of carry it on. And then I think in terms of unpaid carers, again, a lot of recognition about the fact that we're supporting them well, but again, just to make sure that we can keep those wait times down, as we have been able to achieve. I think in terms of our partnership working, definitely some recognition that we've got really strong partnerships. The bit that we didn't necessarily evidence as well as we could have done was the impact of those partnerships. So again, that's something that we're looking at. But principally, it was around that consistency of experience and making sure that there weren't sort of pockets where people's experiences were vastly different to somebody else's, really. So that's principally where we're at the moment. We have got an improvement plan that we'll be working on now. We've acknowledged the report. That initial acknowledgement gets sent back to the Department for Health and Social Care, which we've done. So we're now in the phase of working on our improvement plan, which will kind of focus on those kind of key areas. That has to be submitted by the middle of September. So we'll make sure that we're obviously comfortably within that timescale. And that's a piece of work that will be kind of, again, co-produced with our staff and some of our focus groups that we run. So that's kind of where we're at the moment. but happy to answer any questions if anybody's got anything.
Thanks, Tim. So once you've submitted the improvement plan, do you get any feedback from them?
Yeah, my understanding is that we'll get feedback from that. We also have a sector-led improvement organisation that works to support us, funded by the Department of Health and Social Care, and they support all councils with their improvement plans. And then obviously we will get what we call an annual conversation with Care Quality Commission. So we don't know exactly when that will be yet, but every council will get what they call an annual conversation. And in addition to that, all councils will get a full kind of comprehensive assessment again, depending to a degree on what their outcome was from their benchmarking assessment. So, for instance, all those councils that had a requires improvement assessment finding, they can expect to get a full reassessment within a 3-year period. So the longest we would be another 3 years, but likelihood is it would probably be within the next 18 to 24 months, I would have thought.
Okay, thank you. Any questions? Councillor Dower.
Thank you. You read my notes because I was going to ask you about where is the improvement plan and what are the timelines. And I think you've given me the answer there. So you're actually working on that now, and it's got to be submitted by the middle of September. I guess my follow-up question would be, will we be getting to see that?
Yep, absolutely. There's no reason why you shouldn't have that at all. Yeah.
Thank you. That's it. Thank you, Chair.
Thank you. No, I mean, I think, oh, Councillor Allen.
So I was pleased that you said that there weren't any big surprises. Do you think that this writing of this improvement plan is going to be relatively easy because you sort of already knew what the issues were, or were there some sort of unpleasant surprises? I think lack of consistency is a bit of a concern because you've done a lot of work with refocusing the way that you want your practitioners to approach people, the conversations they're having, the patient, very, very person focused. And obviously that culture change takes time, and there's likely to be inconsistency. But is that a worry? Is that something that's concerned you? So I suppose my first question is, so 2-part. One, what do you think that it's going to be relatively straightforward to write your plan? But secondly, were there any sort of real concerns that surprised you that you really think we need to focus on? Thank you.
So thanks for the question. I wouldn't say I'm unduly concerned, partly because, as I say, a lot of the findings were what we'd already expressed in our own self-assessment. I think there are the points around sort of consistency. You're right. The practice changes that we're making and what we're finding through some of our audit work as well is showing that is, because it's such a shift for people, that actually there are areas where we still need to do more, and that's really what the embedding is all about that I mentioned earlier. So I don't see it as a massive mountain to climb, put it that way. And I think it's more a kind of continuous improvement that we would expect to do, as almost like a business as usual approach anyway, really.
Will that influence the way that you support your staff, the training you're going to give them? Will there be an extra impetus to try and cut into that inconsistency so that you're getting a nice balance? Thanks.
Absolutely, we've actually got more engagement with staff planned for early August, so we've already delivered the outcome, which clearly was a disappointment for a lot of staff because they worked really hard, so it's understandable that it's been a bit sort of disappointing, but that said, there's a real motivation to do more now, to really show that we are better than we think we think we're better than they think we are. And I think some of that also reflects the fact that the process, and I think it's fair to say, Care Quality Commission, we're learning as well along the way, because obviously this is the first time they've done this. So that whole process, I think those councils that were assessed at the start of the 2-year period, because it's taken them pretty much 2 years to do this, probably had a different experience to the councils that came towards the end, because as they were learning as they went along, you know, what the types of questions that they need to ask, the sorts of things that they need to look at. That said, I think there's probably still some areas that they would probably look at and say, yes, we might do that differently next time. And part of it is a question of what they hear, you know, when they're talking to people, and triangulating that information. And sometimes I think we felt that there were some comments that might have been made that were kind of almost isolated sort of situations, but they tend to be sort of taken as a whole, you know. So yeah, I think basically what I'm saying is I'm confident that, you know, we can sort of put an improvement plan in place that gets us to where we need to be, you know, in time for our next full assessment.
And I'm assuming from what you were saying about they don't want to just check this is not a flash in the pan. They want to know that this is a consistent change, and that change is really like baked in. I hope that would mean that if you do achieve that next time they will really reward us for that, if you like.
Yes, absolutely. I'd like to think so. Yeah.
Yes, I think they better hard. Because yeah, because the team worked really hard to get through it. I mean, it's a huge inspection. They don't like calling it inspection, do they? But it is. It felt like it. I think the important thing is, from my reading of it, having read the report, that there was nothing that was coming out of left field, thinking, oh my heaven's sake, I didn't see that coming. So there was nothing like that. So that was reassuring. And I also read the CQC inspection report for Southampton, which came out pretty much around the same sort of time. And they also were required improvement. But this is the thing about that category, that it's a huge scale. And if I was in Southampton, I'd be a lot more worried about some of those scores than what we saw from the feedback on BCP.
You can't have a caveat, but almost there.
Yes, it would be nice to break that down, you know, break that category down a bit. But there we go. But anyway, any other questions on that? Thank you for that, Tim. That's really helpful, and we'll no doubt we'll come back to it later once we've had time to have a think about the improvement plan. Not going to think of another name, Tim. Get a better plan or something. Okay, thank you very much. Right, we're moving on. The work plan. I'm not going to spend a great deal of time on the work plan other than to say it's there. And anybody wants to raise any questions on it? What one thing that I perhaps just want to say, and I'll probably get into terrible trouble for this, but please don't see it as any kind of tablet of stone. It's not intended to be that. It's just a plan to work through a series of issues that we know people are interested in having a look at. But it's not, it's not completely fixed. So if anything emerges, we will somehow or another find a way of dealing with it. And officers will know that I'm not shy about asking difficult questions. But there we go. So anything on the work plan? Okay, thank you very much indeed. David, portfolio holders update, please.
Made a few notes, but it's a bit shorter than last time, because when I looked at when the last meeting was, it was only 2 months ago, wasn't it? So and you've already covered quite a few of the things that have been going on in the last couple of months anyway. So obviously my first point was about the CQC assurance outcome, which has already been covered by Tim. But I think what I would say is there was some media coverage following on from that, which we were involved with. I was quite pleased actually because it was quite fair and balanced, the media coverage of it. I think you're always at the whim of the media if they want to sort of try and make a story out of things. But actually, you know, when a few of us were sort of interviewed and spoke to the press, and I think they could see there wasn't a story, a big sort of public interest story there. You know, that it was what it was. I think, which I was pleased with, because I think, regardless of press coverage, my fear was that if they tried to make something out of it, would be the impact on our staff morale and the staff that were involved in all of the work. And I think it was really important to make sure we got some sort of fair and balanced media coverage, because the staff sort of deserved that really after all the work that had gone into it. And I've sort of been pleased to have heard the sort of way that it's gone down, and that they're responding to the sort of improvements that we need to make. And I think I would be more worried if we didn't already have the sort of all the strategies in place and progressing, that some of which you've heard about tonight: learning disability big plan, the fulfilled lives programme, you know, and all the other strategic plans that we've been putting in place over the last couple of years. And you know, they're all moving us in the right direction and making improvements. So I think because we've got those in place to back up what we're doing, that, you know, gives us confidence that we can move that score up to that critical sort of barrier to get to good. Other than that, since the last meeting, we had the Health and Wellbeing Board a couple of weeks ago, at which we discussed the BCP Suicide Prevention Action Plan, following that being discussed at the last ONS board meeting. And so that was we had a really good discussion. And obviously the Health and Wellbeing Board, that's with a lot of our sort of health partners and voluntary sector and other partners in the room there. So it was really good to have an airing of that and a discussion of that, as well as the other big subjects we had at Health and Wellbeing Board around neighbourhood health, and also our health and wellbeing strategy, which, as I mentioned last time, we've been consulted on. And so we've got our health and wellbeing strategy was agreed and went through the Health and Wellbeing Board. One other thing I think of quite interest, public health, obviously they've been involved quite a lot with the Suicide Prevention Action Plan, but our public health consultants have been working on a gambling harms health needs assessment as well recently, and I've seen a draft of that and had discussions about that. It had been raised a few months ago, and they see that sort of responding to sort of gambling harms being a public health led sort of need. So yeah, it's a really good. It was actually I read through the report. It feels like a bit like an academic report, citing lots of sort of different evidence, but that's what public health is about evidence-based policy. And so it was actually a really sort of interesting read. Other than that, the only other thing to report was that so last week, it's 8th of July, just over a week ago, we welcomed the Labour Secretary of State for Health and Social Care, James Murray, came and visited Figbury Lodge Care Home in Camford Heath to have a tour and see. I think while he was down at LGA conference, he wanted to go and see someone. I think it was really good to take him to see a care home, actually, because obviously a lot of his sort of brief would be around the sort of health service, and we met with him, one of his special advisors, his PPS. So it's good for him to see one of our sort of flagship care homes that we as a council own and is operated on our behalf. Whether he's still the Secretary of State for Health and Social Care, I'm not sure. There's nothing come up in the news yet today, but you can see who a few of his cabinet colleagues are already today, but we shall have to wait for the next day or two, I suppose, to see whether he stays in that post. I hope he does, because we had a bit of a word with him and persuaded him, so don't want to waste that. And he's only been in the job about 8 weeks, so I think he needs a fair crack of the whip. But yeah, so that's really my update.
Thank you. Any questions? One of the things about public health, David, it's a while now, isn't it? It feels a while since we made that decision to split Dorset and BCP. And I'm just wondering if there's any intention at any stage to kind of take stock of how that split's worked. From where I see it, I think it was a really positive thing to do. And I think we're getting benefits, definitely getting benefits from it. But I'm just wondering if there's anything other than my kind of anecdotal assessment that might be able to be considered. Laura, did you? Sorry, have I dropped you in there
Yeah,
with that
sure.
question?
No, I mean, it's a good point, actually. I mean, it's something that's sort of occurred to me. And I think anecdotally, like you, I sort of felt there's been a few areas where I think actually that's been really helpful to have the public health director and consultants in the room, in the building, you know, and able to sort of come and talk to us about things, whether that be around, and I suppose it's just for the things that they need to emphasise that are more of a need within BCP conurbation than when previously it was across the whole sort of Dorset area, particularly suicide prevention action plan, things like gambling harms, health needs assessment, and other areas. So I know there's work going on about sort of meningitis. You know, I've had discussions. Obviously, we've got a big university here as well, so that's quite an important issue. Well, we've got 3 universities within BCP as well as a college. So yeah, there's certain areas I've thought actually, yeah, it feels like it was a good move. So.
Yeah, I guess just to add to that, I think it has been a really positive mood. Sorry, I'm Laura Amble, I'm Corporate Director for Wellbeing, so adult social care, commissioning, housing and public protection, and public health are within my directorate, and I work obviously alongside David and others. So yeah, I think it has been really positive. What it has shown us is that I think it's been fantastic in such a short space of time, actually, to have landed the team really successful. I think our Director of Public Health has been fantastic in building a really strong team around himself. We've got real clarity in terms of those programmes and what matters to BCP, as David says, understanding what makes sense to still keep and think about Pan Dorset, but then being able to have that flexibility to think much more locally and what's much more appropriate for Bournemouth, Christchurch and Poole. And we've had some really, really great programmes that we've seen, not least the health and wellbeing strategy. I think that's been a really good, robust, quality piece of work. It's had public consultation and engagement. We're now to the stage of having the action plan and implementation. A lot of close working as well with health colleagues around things like neighbourhood partnership working, and actually we're doing that cross directorate as you would expect us to do so. What they're looking at now is around those commissioned services that we had. So coming to an agreement with Dorset about which ones should still be commissioned Pan Dorset and which ones are sensible to move forward on a BCP footprint. And again, I think those discussions have gone really well, and that is testament to the teams involved, both in BCP and in Dorset. So that close joint working is still there. And I think, yeah, we're really pleased with how that's gone. And I think the traction that we've gained over such a short space of time, really. So yeah, I hope that helps a bit.
Yes, thank you very much. Councillor Allen.
So if I could just pick up on that a bit. I advocated for us to have our own public health for a long, long time. So I was really, really pleased when it finally came to fruition, and I was pretty confident that we were going to see benefits from that because I think it's so fundamental. I've heard our lead, our public health lead, talk about potentially the opportunities that having our own public health gives us, particularly about place-based services, place-based commissioning, especially with the commissioning getting bigger, the ICB, that's the word. God, my brain's not working. The ICB getting a little bit bigger, and in that way, that causes you a little bit of anxiety because it feels like you're going to be a small fish in a very big pond rather than a Dorset ICB. Do you see that actually having having our own public health will eventually lead to us being able to perhaps go back to getting more place-based services and commissioning? I'm just interested if you think that is the direction of travel, because Rob certainly made a reference to that in the past. Thank you.
Yeah, very much so. And David and all of the directors across Wellbeing and myself have been working very hard to work closely with the ICB. So they have clustered, and as we know, they cover 6 local authority footprints now. They are very clear in their new organisational structure that they will focus on a place-based approach. So you saw Mark, who, congratulations to Mark, he's the Deputy Place Director for BCP. We also have a Place Director called Becky Whale, So their structures, as they restructure, we've heard that they're going through a lot of change. They've deliberately put a place-based team. It's modest, but they have one for each local authority. And that's a direct reflection of the fact that they recognise we need to do more at place-based level. Certainly in terms of commissioning, that's the way that we've been working with them. So Zena has been working really hard with colleagues to work with the ICB to understand where those opportunities are. I think you're right. The commissioning landscape, there's going to be more of it that we need to think about jointly. Even if we're not thinking about it jointly, how are we aligning to make sure that we really get the most from all of those joined up services? So place-based commissioning, I think absolutely, because the ICB are going to be a strategic commissioner. That's their main role now. And I think our response to that has been a really positive one and a timely one. So we have put forward proposals to have a place-based partnership. So that's been approved both on the ICB side and also on the BCP side. And we will look to have that first meeting of the place-based partnership in about 3 weeks' time, mid-August. So I think we've sort of, hit the ground running in that respect. There'll be slightly different timeframes across the 6 different local authorities, but I think we're one of the forerunners that's looking to get that set up in shadow. The purpose being that over time we should have delegated funding and responsibilities on that place-based footprint. So I think it's really good news. And yeah, Rob and the team and Zena and the team, everybody's worked really hard to make that happen. And I think, David, you turn up at just about every ICB forum that we can to champion an advocate.
Yeah, I think particularly it's been good having the public health director for one reason, in just in terms of the BCP brand in terms of health and wellbeing, because one of my concerns with the ICB clustering, they were looking, we've got the sort of Dorset ICB, Wiltshire, Somerset ICB all coming together. And I was on a meeting last week with other adult social care and health and wellbeing portfolio holders, and we had a presentation from somebody at NHS England, and he was talking about the importance of engaging with your ICB cluster. And to be frank, we've gone mob-handed when they've given us the opportunity to actually engage with them, because I was determined, we wanted to make them aware that when they were talking to us, they're not talking to the Dorset ICB. No. Dorset and BCP are quite different areas in terms of different demographics, different needs, different ambitions. So I think on the wider ICB cluster, they needed to understand that BCP wasn't just a corner bit of Dorset and Dorset's Dorset, that actually we're different and we have different ambitions and want to engage with them in a different way. So we have gone, and Rob's been key to that, and Laura, the fact that we've got Laura who can talk their language, having come from that background, and
that's a good thing.
And I think Rob as well, he's his experience in Swindon previously has worked really well in terms of actually sort of working with this sort of emerging ICB cluster. And even Aidan came along to one of the ones we had at Wincanton Racecourse. He came, Aidan, right from the chief exec level, came to that meeting with the ICB cluster people to show that we're serious about sort of actually wanting to sort of work with them and progress stuff for our area. So so I think it's gone beyond a bit beyond public health, but I think public health and the wider sort of ICB engagement work, I think is working really well. So
that's music to my ears, because I do think you have got to really you've always got to see these changes as opportunities rather than, oh my gosh, it's going to be so big and we won't have a voice and it just will get lost in the, actually it's an opportunity to go, well no, actually, by the way, we're here and we're different and we really need you to take an interest in us. And then the other mood music I'm getting sort of ICB is about outcome, that they're going to be doing outcome-based commissioning, not just we'll commission and worry about it later. We're actually going to expect you to deliver on outcomes, and that's going to be how you're going to be. Is that still what you're hearing? Thank you.
Yeah, absolutely. They have a outcomes-based commissioning framework. It's interim at the moment, and that will develop. It takes into account the local authority outcomes framework as well. So actually, I think that's really, really helpful, because everybody's pulling in the same direction, everybody's on the same page. And I think, moving to outcomes-based commissioning as opposed to activity-based, counting widgets, if you like, and more thinking about the so what and the outcomes for people. That's the way I think that we're all moving. So that's really helpful. And the fact that they're doing that in a very aligned way I think completely marries up with what we all want to achieve, and that will be really important as we go forward through neighbourhoods.
And that's completely in line with what you're trying to do within adult social care, isn't it? Completely. So that's good. It's good that we're a little bit ahead of the game. So that's excellent. Thank you. And I wanted to say earlier and didn't that, you know, I think that you've made some real strides with the reconfiguration of your services, and I think that it's a shame that that wasn't actually perhaps as happily shown in the CQC, because I do think that, you know, you are on track and you're coming back and you're telling us and you are delivering on what you said you were going to do, and I do think that's excellent, and I do think we should shout quite loudly about that. I'm, you know, as a scrutiny board, and yeah, and it's a shame that I know they want to know it's baked in, but it's a shame that they didn't give you a bit more credit for that, I think. So thank you.
Thank you very much. Thank you, David. Any final points anybody wants to raise? Thank you, everybody, for that. Just one final bit to highlight, and that's the corporate performance report for Q4. That's just there for your information. It has been circulated, I think, fairly widely now, but it's just there for noting. So if there's nothing else, I think we've reached the end of the agenda, and thank you all very much for attending and for your help with this. Thank you very much.
Thank you.